All and welcome once again to my NCLEX review. Today we're going to be doing the respiratory system, some disease and conditions that you may encounter on your NCLEX. Okay, let's start with tuberculosis. As you all know, tuberculosis is an infection of the lung caused by Mycobacterium tuberculosis. The pathophysiology of tuberculosis is transmitted via aerosolization and attaches to the alveoli, also known as the ear sac, which trigger an immune response, ingestion of the bacilli by macrophage and formation of granulomas or lesions. What are some clinical manifestations of tuberculosis? Cough. A cough that lasts greater than 3 weeks, purulent and or bloody sputum, night sweats, weight loss, lethargy. Okay? How do you diagnose tuberculosis? Quantiferin, gold blood test. Also, the Montauk test can be read within 48 to 72 hours. However, those tests could indicate positive. However, the diagnosis will be made by the sputum culture, the acid-fast bacilli culture, 3 early morning sputum sample will diagnose tuberculosis. The chest x-ray shows active lesion in the lung, but the sputum will be the one to diagnose the disease or the condition. How do you treat it? There are several drugs that can be used, like rifampin, isoniazid, pyrazimide, ethambutol. Those are the drugs that they would normally treat tuberculosis. They could go from 6 to 12 months, all depending on how active the tuberculosis is. Okay? So the nurse place the patient in a negative airflow room. They are to wear their mask, the N95 mask, to go into the patient's room. The other type of respiratory, let's go back to tuberculosis. They also have another type of tuberculosis, such as miliary tuberculosis. That's the tuberculosis that disseminates through the bloodstream. Okay? It could attack the kidneys. It could attack any other organs. Miliary. It's a form that disseminates through the bloodstream. So if you were to ask, tuberculosis, yes, it is more prevalent in the lung, but anyone could have tuberculosis in other parts of the body. The next respiratory condition is like a pulmonary embolism. What is that? A pulmonary embolism is a life-threatening situation in the pulmonary by vasculature. What's the pathophysiology? An embolus. It could be an embolus from a deep vein thrombosis, became large in the pulmonary circulation, or the pulmonary vascular occlusion, which leads to impaired gas exchange and circulation. Impaired gas exchange, inadequate inhalation of oxygenation, and exhalation of carbon dioxide. So what are the risk factors for pulmonary embolism? You do have many risk factors, such as immobility. When someone is laying or sitting in one position, you're immobile, it places you at risk to develop an emboli. An emboli is a clot, okay, that breaks off and could go any parts of the body. That could cause a life-threatening situation. Okay, it could be smoking. Smoking is a major contributor to an emboli, or it could be a combined oral contraceptive. Obesity is a factor. Surgery, atrial fibrillation, okay, where the heart beats so rapidly it quivers, okay. All those are risk factors for an embolism or a pulmonary embolism. So what are some clinical manifestations or signs and symptoms of pulmonary embolism? Shortness of breath, chest pain with inspiration, tachycardia, very fast heart rate, tachypnea, very fast respiration. The blood pressure is going to be dropped, hypotension. The patient will also have petechiae, diaphoresis. What labs you should go over? The D-dimer. The D-dimer is a lab that indicates pressure or the presence of a clot. They will diagnose this with a CAT scan. What are medications that should be administered to prevent an embolism? Is anticoagulant. Anticoagulant, patient is hospitalized, they will use heparin, okay, warfarin, or other thrombolytics medications. They could also do surgical procedure such as a thrombolectomy, or thrombectomy rather, removal of the clot, or a vena cava filter that prevents an emboli, okay, from entering the lungs. So what's the nurse's duty? You want to sit the patient upright. That helps to expand the lungs. You want to administer oxygen to that patient. And also, you want to have the warfarin therapy, frequent blood drawn needed to monitor the patient PT and INR levels. Okay, you want to maintain a consistent intake of vitamin K to prevent bleeding. You want to instruct patient no aspirin, prevent falls, okay, things like that. Be careful of using electrical shavers and soft toothbrush to avoid, and also avoid blowing of the nose forcefully. Those things when the patient is taking warfarin therapy. Also, to prevent a deep vein thrombosis, you want to instruct your patient to stop smoking. Smoking cessation is paramount, okay? Increase mobility and wear compression stockings. So that would be pulmonary embolism. Let's talk about acute respiratory distress syndrome, okay? there are many factors that could cause an acute respiratory distress syndrome. Okay, for example, sepsis. Someone has sepsis, like a bacterial infection that disseminates through the bloodstream. Yes, they are at risk for acute respiratory distress syndrome. Shock, trauma, pneumonia, someone with pancreatitis, inhalation of chemical, okay? Someone who is submerged in the water could also go into acute respiratory distress syndrome. What are some clinical manifestations or signs and symptoms of acute respiratory distress syndrome? Dyspnea, rapid, shallow breathing, tachycardia, substernal retractions, cyanosis, pallor, crackles. The fetus in the utero also could have acute respiratory distress syndrome if the fetus passed meconium in the utero. The fetus could be under a stressful situation where that baby would defecate. That meconium is the first stool inside of the utero, and swallow that stool, which could cause acute respiratory distress syndrome or haline membrane disease. And that could create major issues with that baby. Sometimes the baby needs to go on a mechanical ventilation. Okay? So the treatment, you want to correct the underlying cause. Oxygenation is paramount. Mechanical ventilation, as mentioned before. So what are some nursing care? You want to maintain patient airway. You want to monitor cardiac status, patient's heart rate, patient's blood pressure, and you want to provide mechanical ventilation care. The next respiratory condition that you may encounter on your NCLEX is that of asthma. So what's the pathophysiology of asthma? Chronic lung disease that causes narrowing and inflammation of the bronchi and the bronchioles. Intermittent and reversible. Remember now, if you were to ask, asthma is part of the criteria for COPD. You have asthma, you have chronic bronchitis, and you have emphysema. And of the three, asthma would be the only condition that consider reversible, meaning that it would not cause major destruction to the lungs over time, which could cause the lung to go into respiratory failure. Asthma attack, you want to soothe the muscle contraction because the chest tightens, patients start having dyspnea, so you want to use a bronchodilator right away. What are some clinical manifestations of asthma? Shortness of breath, easy fatigue, cough at nights, trouble sleeping, sneezing, tired, scratchy throat, wheezing, decreased peak flow. Okay, so those are some early signs. Remember, when you're reviewing this, you want to know what are the early signs, what are the active signs, what are the very worsened signs of asthma. Okay? You got to know your triggers. Triggers Knowing the triggers, then you could stop or avoid certain things that causes triggers. So what are some triggers of asthma? Smoking, pollen, pollution, perfume, dander. Remember, some asthma triggers by the environment, the weather, whether it is too hot or it's too cold outside or it's just in between. So the weather could be a factor in causing triggers of asthma. Another condition that mimics or could trigger asthma is gastroesophageal reflux disease, also known as GERD, where they regurgitate the food, and that could cause burning in the esophagus. Okay? Respiratory infection, exercise, hormonal shift. Patient may be on a beta blocker, okay? Or taking some non-steroidal anti-inflammatory drugs. Okay, aspirin is a major trigger also for asthma. Just mindful that you got to, in the acute phase of asthma, you got to remember, you got to give a bronchodilator, such as albuterol. Albuterol, short-acting, fast relief, not for daily treatment. Okay? Another short-acting bronchodilator is that of ipratropium. Ipratropium, that's a short-acting bronchodilator. And then for maintenance dose, you want to give us like a Solomedrol. Solomedrol is a long-acting. It's not for acute attack. Remember, if you see questions like that, you would not give a Solomedrol in an acute phase of an asthma attack. Okay? Because your goal is to help that patient to survive. You do have other medications that can also work for asthma, like an anti-inflammatory drugs, like a corticosteroids. Corticosteroids is not for an acute attack, but it helps remove some of the inflammation, okay? Another anti-inflammatory drug, such as a Montelukast, it's an oral medication that relaxes the smooth muscles, okay? And that is also a maintenance drug, not for an acute episode. Let's talk a bit about a COPD, chronic obstructive pulmonary disease. You may ask, what's the main factors for this? Smoking. Smoking is a major contributor for a COPD patient. Okay? It is characterized by airflow obstruction that causes by chronic bronchitis or emphysema. The obstruction is caused by inflammation, which changes the structural function of the lung, make it harder to get rid of a CO2. They hold on to the carbon dioxide. So you got to be careful when you're administering oxygen to a COPD patient. You want to give supplemental oxygen. Supplemental oxygen, no more than 1 to 3 liters. If you're going to give more, you may have the patient become worse. That patient could go into respiratory arrest. So what are some complications of a COPD patient? Pulmonary insufficiency, acute exacerbation, pulmonary hypertension, and something called core pulmonary, where the right ventricle become hypertrophy. Okay? What are the risk factors for COPD? Smoking. Occupational. That patient may be working in an environment where they have dust, chemicals, vapors. All those are contributors to COPD. You got to know some of the clinical manifestations, like a barrel chest. Know the difference where a COPD patient, like a chronic bronchitis, they will have something called blue bloaters, where they gain weight. If you look at their features, they are cyanotic. And in contrast, emphysema, they are also known as pink puffer. Emphysema patients, they're very thin and emaciated. So know the difference. Chronic bronchitis, you have a blue bloater, and emphysema, pink puffer. Go over your clinical manifestations of the signs and symptoms of COPD, okay? And late stages, they will have dyspnea, shortness of breath at rest, okay? They rely on their accessory muscle, or accessory muscle rather, to breathe. Wheezing, chest tightness, fatigue, and weight loss. How do you diagnose this condition? They will do chest x-rays, okay? They also will do the incentive spirometer. How do you treat it? You want to treat with bronchodilators, okay? Sometimes surgical procedure, like a bulectomy or lung transplant. Remember, respiratory, these patients will have prolonged expiration, decreased breath sounds, accessory muscle breathing, decreased diaphragm movement, and remember, they will have an acid-base imbalance such as respiratory acidosis. Cardiovascular, if you observe these patients, they will have jugular vein distension, edema in the lower extremities, and at times they may have dysrhythmias. The next one is pneumonia, okay? Pneumonia, they do have different types of pneumonia. You could have aspirational pneumonia, bacterial pneumonia, viral pneumonia, okay? Of all, the bacterial pneumonia could be very dangerous, and also aspirational pneumonia, because the food particles can enter the lung, which could cause major complications for that patient. So go over what are the clinical manifestations of pneumonia. You got to know your early signs because the boards or the NCLEX will ask you what are the early signs versus the late signs of pneumonia. So early signs, you may have purulent sputum. If you auscultate the lung, you're gonna have diminished lung sounds, fatigue, coughing, sore throat. And in contrast, late symptoms, chest pain, tachycardia, sepsis, dyspnea, activity intolerance, because the patient is going to be experiencing weaknesses, hemoptysis, spitting up blood, and respiratory distress. What are some common causes? It could be abdominal thoracic surgery, IV drug abuse, air pollution, immunosuppressive disease. For example, the patient may have HIV/AIDS. The patient could have cancer. The patient could also have transplantation. Any of those factors can lead to pneumonia. Age, older than 65, interstitial or intestinal gastric feeding, such as a nasogastric tube. Any of those factors could cause pneumonia. Bedridden. The patient is immobilized, patient unable to move around, therefore the lungs is not going to be able to expand. Yes, the patient could end up with a pneumonia. Diabetes, lung cancer, recent antibiotic therapy. Any of those factors could cause pneumonia. Let's talk about chest tube. What are the uses of chest tube? Chest tube is to remove air and fluid or blood. It could be the patient had a pneumothorax, a hemothorax. The patient may have a thoracotomy, okay, a lung surgery, and they want to reestablish the lung, okay? Any of those fracture, pleural space, for restoring negative pressure with the pleural space to expand the lung, okay? So how do they place it? Mild anterior axillary line at the 4th and 5th intercostal space on the affected side. What are some complications of chest tube? Bleeding, infection, air leaks, also known as crepitus, clogged tubing. Just remember, you could check for kinking. Say the patient has a chest tube, you enter the room and you notice there's no drainage in the chamber, so you want to check for kinking. But one thing you would not do is to milk the tube or strip the tube. That is not your duty. Tube disconnect. Okay, you want to place the chest tube in sterile water. Okay. Let's talk a bit about flare chest. What's the pathophysiology of a flare chest? It occurs when rib cage fracture. Someone may sustain injury which causes their rib cage to become fractured and they develop flare chest. Other causes: severe blunt trauma, symptoms, tachycardia, dyspnea, tachypnea, hypotension, cyanosis. Cyanosis, meaning that the patient is lacking oxygenation. Chest pain, okay? Paradoxical breathing, diminishing breath sounds. All those are clinical manifestations or symptoms of FLAIL, F-L-A-I-L, flayed chest. And how do you treat this? You want to administer oxygen? Patient may end up on the mechanical ventilation, IV hydration, and possible surgical intervention. Let's talk about tension pneumothorax. What is a pneumothorax? It's air, the collapse of the lung. So tension pneumothorax is a life-threatening situation. It's a medical emergency that develops when air is trapped in the pleural space or the pleural cavity under the positive pressure. The air that enters the lung, the chest, a cavity, which each inspiration is trapped. So what are some signs and symptoms that your patient would be experiencing? Acute respiratory distress, hypoxia. What is hypoxia? It's lack of blood going to the tissues. Cyanosis, agitation. If you look at that patient, distended neck veins, drop in the blood pressure. How do you treat this? What are some treatments? Emergency thoracotomy. Thoracotomy, they're going to enter the lung, okay? So this patient will end up with a chest tube. Chest tube insertion. Thoracotomy, incision in the chest wall. If you were to ask what intercostal space is between the fourth intercostal space, mid-axillary space, the second and third space at the mid-clavicular line, right side only. You put a little check there. So I think these sort of things may pop up on your NCLEX. Let's talk briefly, because you may encounter like cystic fibrosis. Cystic fibrosis, it affects young children. You may have babies born with cystic fibrosis. And what is that? It's a disorder that severely impairs the lungs, causes dysfunction in other organs. Why? That makes the mucus or sweat. Just remember, cystic fibrosis, if you were to ask, it's an autosomal recessive disorder, causes obstruction of sodium transport within the cell membrane or membranes, producing secretion with low water content. So these patients, they suffer dearly. Okay, they have very sticky mucus that plugs the organs, duct. So what are some organs that involve? Pancreas, the lungs, the liver, the small intestine, the reproductive organs, okay, which leads to organ failure. So respiratory, that involves wheezing, coughing, dyspnea, cyanosis. You will find patients with cystic fibrosis, they do have barrel chest. They have clubbing of the fingers, chronic respiratory infection. Just remember the GI. What type of stool? Very fatty, malodorous stool, also known as tetrarrhea. Babies or children born with cystic fibrosis, they do have delayed growth, fat-soluble vitamin deficiency, A, D, E, and K. The skin, they have high sodium chloride content in the sweat, the saliva, and tears. So you got to check the labs. Sweat chloride test. Don't forget that. Cystic fibrosis, sweat chloride test, DNA testing, PFT testing, stool analysis. How do you treat cystic fibrosis? Bronchodilators. Remember, these patients, they have very thick, sticky mucus, so the lungs is not expanding readily. So they will have major difficulty breathing. So bronchodilators. What are some bronchodilators? Albuterol is one of your bronchodilator. That's a short acting. Okay? Anticholinergic drugs. Dornase alpha. Antibiotics for pulmonary infection. Pancreatic enzymes. Pancreatic enzymes take with meals and snacks. Mucolytics. And remember the procedure, chest physiotherapy. They normally would do chest physiotherapy prior to mealtime. That helps to break up the secretion, giving the patient a more comfortable period so they could have their meals. So chest physiotherapy, you want to use your percussion and your vibration. Postural drainage and breathing exercises. Schedule treatment before meals, as mentioned. It is so vital, or at least 1 to 2 hours after meals to avoid vomiting. And you want to use your bronchodilators 30 minutes to an hour before treatment. You need to administer O2 high. You want to encourage fluids, okay? Protein and diet. And that concludes respiratory. I hope this will be helpful for you for your preparation of your NCLEX, whether it's NCLEX PN or NCLEX RN. Please like, subscribe, share, and comment on this video. Thank you so much, Dr. Miller. Bye-bye.